Hello friends, today we are going to discuss about sepsis and septic shock updates from the 2024. Definition: life-threatening organ dysfunction with suspected or confirmed infection defined as Phoenix sepsis score of more than or equal to 2. Organ dysfunction may include respiratory, cardiovascular, coagulation and neurologic system. So we'll see what is Phoenix sepsis score. Phoenix sepsis score includes respiratory parameter, that is PF ratio of less than 400, SP ratio of SF ratio of less than 292. Then 2 points are allotted to PF ratio of between 101 to 200, SF ratio between 149 to 220. 3 points has been allotted to PF ratio of less than 100 and SF ratio of less than 148. Then cardiovascular point, 1 point given to if the patient is on the one vasopressor and the lactate is between 5 to 10. 2 points are given if the patient is on the more than two vasopressor support and lactate is more than 11. Then coagulation, 1 point each for platelet less than 1 lakh, INR more than 1.3, D dimer more than 2, and fibrinogen more than 100. Then neurologic, 1 point is given to the GCS score if less than or equal to 10 and 2 point if the fixed. Now, pathophysiology of the sepsis. At its onset, sepsis manifests as an overwhelming release of inflammatory mediators in response to the infection. An analogy can be drawn between the immune response to the infection and national defenses. Component of the innate system or citizen at the site of pathogen exposure activate and recruit the circulating immune cells and the troopers like neutrophil, natural killer cell, dendritic cell, platelet, monocyte, and eosinophil. These cells have pathogen recognition receptor on their surface, which bind to and are activated by pathogen-associated molecular pattern on bacterial cell wall and damage-associated molecular pattern host molecule released when the danger signs from the pathogen burn and trauma. These receptor binding initiate intracellular signaling cascade, resulting in activation of cytosolic transcription factor such as nuclear factor K beta and activator protein 1, which in turn lead to the production of several acute phase reactant involving cytokine coagulation factor, inducible nitric oxide synthetase, thus initiating immunoinflammatory cascade. And subsequent chain reaction involves activation of even stronger armed forces, the adaptive immune response. This explosive activation and the resultant immune cytokine storm are believed to be the causative pathway for septic shock. An end response to the infection is often combination of pro and anti-inflammatory cascade. Once infection resolved, the balance is established between immune upregulating and down-regulating process, and immune memory is generated to protect against future exposure. However, when initial response is excessive and dysregulated, this balancing process is become dysfunctional. Sepsis persists by about 24 to 48 hours. A shift towards hypoinflammatory state is observed, and patient develop feature consistent with immunosuppression. This phase is known as sepsis-induced immunoparalysis, and the majority of septic shock-related death occur during this immunoparalytic phase. These patients are often not able to clear initial infection and in addition are predisposed to new infections from the nosocomial pathogen. T cells and B cell exhaustion, apoptosis, and energy are now recognized immunosuppressive mechanisms observed in patients with the fatal hepatitis. Although pattern of hyperinflation and the hyperimmunity followed by hypoinflation and hypoimmunity is most common presentation of sepsis, it should be noted that some patient presents as hypoinflammatory and hypoimmune from the outset. So this is the Q-SOFA. What is the Q-SOFA score? Q-SOFA criteria if more than or equal to 2 of the following is present. That is respiratory rate more than or equal to 22. Then change in mental status and systolic blood pressure less than 100. Now about management of the sepsis. Successful treatment requires fluid resuscitation with focus on perfusion and early administration of antibiotic. In 2018, Surviving Sepsis Campaign Bundle updated introduced 1 hour bundle, which was largely written for patients with septic shock in 2021 Surviving Sepsis Guideline. The bundle combines elements of the prior 3 and 6 hour bundle into algorithm that emphasize the immediate treatment of the septic shock patient. So the first element of the bundle are diagnostic, measuring lactate level and obtaining blood culture prior to the administration of antibiotic. The remainder of the bundle address management is early antimicrobial administration, fluid administration if required, and vasopressor support. Now the management is successful management requires fluid resuscitation with focus on the perfusion. So surviving sepsis campaign, measuring lactate level, uh, following serial measurement if initial level is more than 2. Obtain blood culture prior to administering antibiotic. Administer broad spectrum antibiotics. Then begin a rapid administration of 30 ml per kg of the crystalloid for hypotension and or lactate more than or equal to 4. Start vasopressor if the patient is hypotensive during and after fluid resuscitation to maintain mean arterial pressure of more than or equal to 65. 1 hour bundle, the 1 hour bundle was met with some resistance, however, and despite observational data suggesting the importance of timely treatment of septic shock, and there is lack of high quality prospective evidence supporting the shift. Additionally, in the area of quality metrics, many groups have expressed the concern that compression of timeline could lead to the overdiagnosis of sepsis and thus overuse of antibiotic and excessive volume resuscitation. So the effect of 1 hour sepsis bundle on in hospital mortality in patient with sepsis in emergency department. A randomized control trial is ongoing multicenter randomized control trial that aims to address this concern specifically. So early administration, early antimicrobial therapy and source control. For patient with the presumed sepsis, early empiric broad spectrum antibiotic therapy should be initiated within 1 hour of presentation, especially patient with the septic shock. Ideally, microbiological sample from the suspected foci of the infection should be obtained prior to the administering antibiotic. However, if obtaining this sample would delay antibiotic administration, antibiotic therapy should always take priority. Appropriate antimicrobial therapy is essential for decreasing sepsis mortality and should be guided by clinical presentation and local antimicrobial resistance pattern as well as patient's risk factor for particular organism. Chronic comorbidity and presence of invasive medical devices should taken into account when selecting initial antibiotic regimen. When source of the infection is unclear, empirical broad antimicrobial therapy should be administered. For most patients, empirical antibiotic coverage should include either extended spectrum penicillin, third and fourth generation cephalosporin, or carbamazepine. Additional consideration should be paid to the risk of MRSA and if present, empirical vancomycin administration is advised. Combination therapy is the topic of some debate, though some early studies reported synergistic effect with the addition of aminoglycoside to beta-lactam, and later studies assess the addition of fluoroquinone. Combination therapy has been associated with improved survival in most critically ill patients through RCT data lacking. In the appropriate clinical context, the empirical antiviral therapy is appropriate. In setting of immunosuppression, total parenteral nutrition, or recent abdominal surgery, empirical antifungal therapy can also be considered. Once microbiota are available, prompt de-escalation to targeted antimicrobial is safe and is associated with lower mortality rates. Source control has been increasingly recognized as an important element of optimal sepsis treatment. The removal of potential infected invasive device is highly recommended, particularly urinary and central venous catheter. Prompt consultation with surgical and interventional radiology services is required to address scenarios such as empyema, septic arthritis, cholecystitis, and intra-abdominal abscess. Generally, the least invasive intervention method of sepsis source control is preferred, though timeline is also a major factor in selecting between competing options. Multidisciplinary approach to an early intervention. Now about fluid resuscitation. Prompt fluid resuscitation should be initiated upon diagnosis of sepsis. Previous guidelines strongly recommended initiating infusion of 30 ml per kg of intravenous crystalloid fluid within 1 hour of the sepsis identification if hypotension is present. Hence, recent updates have downgraded the strength of this recommended fluid volume. Fluid choice, colloid versus crystal. In 2004, the SAFE trial compared the clinical outcome in critically ill patient receiving volume resuscitation with either normal saline or albumin. No significant difference in all-cause mortality was noted between the two groups, though subgroup analysis showed increased mortality with albumin in patients with traumatic brain injury. The combination of significantly increased expense of albumin infusion and absence of data to support a clear benefit led to surviving sepsis campaign to recommended crystalloid as an initial volume resuscitation agent of choice. Now about fluid of choice, saline versus balanced crystal. Which crystalloid to use is also a matter of active debate. Two large single center cluster RCT, including SMART, which focus specifically on critically ill patients, found decrease in the composite outcome of the mortality, renal dysfunction, and need for renal replacement therapy with the use of balanced salt solutions such as ringer lactate or plasma light when compared to 0.9% saline solution. However, more recent basic and plus trial demonstrated no significant difference in 90-day mortality between the two. So this is the key randomized control trial comparing balanced crystalloid to normal saline in critically ill patients. In 2012, the UNOS et al. The implementation of the chloride restrictive strategy in tertiary ICU was associated with significant decreased risk of AKI and the use of RRT. Then the split trial published in 2015, which showed among patients received crystalloid fluid in ICU, the use of buffer crystalloid compared to 0.9% sodium chloride did not reduce the risk of AKI, RRT, and in-hospital mortality. Then in 2017, SALT trial published a pilot cluster randomized multiple crossover trial preceding SMART, uh, comparing saline versus balanced crystalloid solution in ICU, and it found the no difference in a major adverse kidney event. Then SMART trial published in 2018. It is a large pragmatic cluster randomized multiple crossover trial in favor of resuscitation with intravenous balanced crystalloid compared to normal saline. Major adverse kidney event was lower in balanced crystalloid solution. Then in 2021, basic trial was published. There was no difference in 90-day mortality between resuscitation with balanced crystalloid compared to 0.9% normal saline in critically ill patient. No difference in AKI, RRT, AKI or RRT, and potential harm with the plasma light in TBI patient. Then PLUS trial was published in 2002. The use of plasma light compared to 0.9% saline in critically ill patient did not reduce 90-day all-cause mortality and risk of AKI and RRT in this multicenter large randomized control trial. So next is about fluid balance. While adequate resuscitation is essential, fluid overload is associated with increased mortality, making perfusion assessment essential to the treatment algorithm. Careful attention to the fluid management with transition to conservative fluid treatment management 24 to 48 hours after successful resuscitation is associated with the reduced ICU length of stay, and increased ventilator free day. Additionally, Silverside et al. Found that positive fluid balance at 3D is the independent risk factor for increased mortality. So, Classic and the Clover RCT suggested that more conservative approach to the fluid administration have little or no effect on mortality in ICU patients with septic shock, but did demonstrate safety of relative fluid restriction. Several ongoing studies, including ARISE trial, AVIS trial, and Freshly, will generate the additional data on the potential benefit of conservative fluid strategy and early vasopressor use in the septic shock. In the meantime, based on observational data, that fluid overload is associated with mortality and accumulating RCT data that conservative fluid management is at worst safe. A reasonable modern approach to the fluid management include aiming to achieve and even to net negative balance at 72 hours and using cumulative fluid balance loop to avoid end organ dysfunction resulting from the volume overload. Now, the next is about deresuscitation. A practice of fluid mobilization and evacuation or deresuscitation has gained traction in recent years as a way to minimize adverse effect of the volume overload and potentially decrease the duration of illness. Although minimal prospective literature on this approach currently exists, the realm of sepsis reduced trial aim to explore feasibility of the protocol in ICU deresuscitation with ongoing relief ICCA and the Pro Fluid trial that are studying fluid management using RRT in patients with acute kidney injury in ICU. We may soon have more guidelines into optimal strategies for managing fluid overload in critical illness. So there are four phases of the fluid therapy in sepsis or other critical illness. That is rule strategy. The optimal fluid resuscitation should parallel the phases of septic shock. The first phase that is first 6 hours is resuscitation. When initial aggressive resuscitation recommended to be 30 ml per kg of ideal body weight of crystalloid should be provided. Second phase is optimization when additional fluid bolus are given specifically targeting fluid responsiveness or other specific hemodynamic endpoint to improve organ function. Third phase is stabilization, also referred to as tone and time phase, in which patient remain on vasopressor, but vasopressor requirement are no longer increasing and patient are no longer fluid responsive. The organ function is stable and improving, and further fluids are withheld. The four phases evacuation, also known as deresuscitation and mobilization phase, when the patient with the volume overload are treated with diuretics or ultrafiltration to expedite their return to euvolemia in hopes of accelerating recovery from the critical illness. The time at which given patient transition between the phases varies, and repeated insult may substantially disrupt the sequences. Now about perfusion assessment. In the assessment of perfusion in sepsis, the intensivists have historically focused on normalizing microhemodynamic parameter. The targeted goal for resuscitation have evolved from static hemodynamic rate to dynamic variables such as pulse pressure variation, stroke volume variation, plethysmography variability index, and others obtained through bedside echocardiography measure. However, persistent alteration of microcirculatory blood flow, despite the restoration of macrohemodynamic parameters, can lead to organ failure. At least one study has shown that microcirculatory perfusion alteration predicted mortality during serious infection, where mean arterial pressure and cardiac output did not. This dissociation between microcirculatory and microcirculatory flow underscores the need to assess end organ tissue perfusion in patients with septic shock and to develop tools to analyze microcirculatory blood flow. For example, Persistent hyperlactemia has been traditionally considered as a signal of tissue hypoperfusion or hypoxia. Consequently, lactate normalization is recommended as resuscitation target in the reset guideline. However, pathogenesis of lactic acidosis in sepsis metabolically complex and may have recently criticized the use of lactate as a hemodynamic endpoint of resuscitation, especially when used as trigger for IV fluid administration. Peripheral perfusion is the promising alternative target. This is particularly interest in the scientific community for using the skin, an easily accessible organ as a surrogate for the deeper organ perfusion by using skin temperature gradient, capillary refill time, the extent of mottling, and peripheral perfusion index. The first major RCT using peripheral perfusion as an assay for microcirculatory dysfunction, that is Andromeda shock trial, CRT guided targeted resuscitation strategy did not demonstrate a statistical significant reduction in all-cause 28-day mortality when compared to lactate targeted fluid resuscitation, though there was a trend towards benefit. So this trial demonstrated that CRT could be used to reliably follow dynamic changes in capillary and microcirculatory flow parameter and hypoxia surrogates during sepsis resuscitation. A much larger follow-up trial, Andromeda Shock 2, is in progress, aimed to further stratify patients in septic shock in order to more precisely guide CRT-based resuscitation efforts. Then about vasopressin. Mean arterial pressure is the primary driving factor behind the systemic perfusion. When hypotension persists despite adequate IV fluid resuscitation, vasopressor should be promptly administered. At present, surviving sepsis campaign recommended noradrenaline as a first-line vasopressin. If second agent is necessary to achieve MAP goal, vasopressin is recommended. Patients with the septic shock are hypothesized to have relative vasopressin deficiency, meaning that level of vasopressin are lower than the expected for the shock state. Thus, addition of low-dose vasopressin or analog can be effective treatment for refractory septic shock. Furthermore, the addition of vasopressin has been noted to have dose-sparing effect on norepinephrine requirement, potentially decreasing the risk of tachyarrhythmia and the other catecholamine-associated side effects. In addition, vasopressin has been proposed to have nephroprotective effect in septic shock, but this effect was not seen when assessed as primary outcome of large vanished RCT. Though previously recommended as an alternative to vasopressin as a second-line vasopressor for septic shock, 2021 SSC guideline recommended adrenaline as a third-line agent, particularly for patients with cardiac dysfunction. Notably, given its stability at room temperature, adrenaline remains frequently used first-line agent for septic shock in resource-limited settings. In low dose, adrenaline is an inotrope, but at higher dose, it can manifest vasoconstrictive properties. Head-to-head comparison of adrenaline to noradrenaline or to noradrenaline to dobutamine in septic shock showed no difference in mortality, but increased adverse event with adrenaline versus noradrenaline alone. Notably, adrenaline infusion via metabolic effect of beta 2 receptor stimulation almost invariably causes hyperlactemia, and though adrenaline reduced induced lactic acidosis has been associated with reduced mortality. This effect nonetheless limit the usefulness of lactate clearance as an indicator of response to therapy in adrenaline treated patients. Then previously considered the first-line vasopressor for septic shock, dopamine has fallen out of favor since SOAP2 RCT. Subsequent 2015 meta-analysis found decreased all-cause mortality with norepinephrine compared to dopamine in septic shock. Dopamine should be reserved for selected patients. There are extremely limited clinical trial data about the use of phenylephrine in septic shock, with observational data suggesting that phenylephrine in septic shock is associated with higher mortality rate when compared to dopamine. As such, its use should be limited in patients with sepsis. Angiotensin II is the most recent vasopressor to receive European Medicine Agency US Food and Drug Administration approval following 2017 Athos 3 trial. So, in this multicenter RCT, the group treated with Athos angiotensin II demonstrated significant increase in blood pressure and no significant increase in adverse event. Angiotensin 2 appears to be particularly effective in patients with AKI, and subgroup analysis of Athos 3 demonstrate mortality benefit in patients with AKI receiving RT. Additionally, results from recent observation pilot study suggest that angiotensin 2 may be effective when used as first-line vasopressor for vasodilatory shock, but additional data to define which patients are most likely to derive benefit from angiotensin 2 are needed. A subset patient with septic shock will develop septic cardiomyopathy. These patients typically have little cardiac reserve at baseline and are unable to generate compensatory cardiac output during vasodilatory shock. If cardiac output remains low despite use of vasopressor, initiation of inotropic therapy is appropriate. In the 2021 Surviving Sepsis Campaign guideline recommended the addition of dobutamine to noradrenaline or switching from noradrenaline to adrenaline, as data show similar improvement in cardiac output with the use of single agent adrenaline compared to dobutamine paired with noradrenaline. Now about diagnostic technique. Microbiological culture, positive blood culture are demonstrable evidence of systemic infection. If sepsis is suspected, current guidelines recommended drawing two sets of blood culture, both aerobic and anaerobic. However, septic culture yield is variable and is dependent upon the sampling technique. Care must be taken to adequately prepare the skin with antiseptic agent and to inoculate each bottle with minimum 10 ml of the blood. Ideally, culture should be obtained prior to administration of antibiotic to improve yield. Cultures of other bodily fluid should also be obtained as a clinically indicated, like sputum, urine, and CSF. Lactate. So, as mentioned above, the use of lactate as an endpoint of resuscitation in sepsis has been recently questioned. Undeniably, elevated serum lactate is the marker of disease severity in sepsis. Likewise, normalization of the lactate with resuscitation in early sepsis is predictive of good outcome. However, etiology of rising lactate is multifactorial, potentially including anaerobic metabolism resulting from inadequate oxygen delivery, also including variety of metabolic perturbation unrelated to the fluid status. Prior RCT data suggested that lactate-guided resuscitation in patients with septic shock reduces the mortality, though this finding has not been consistently reproduced. Despite this controversy, in 2021 Surviving Sepsis Campaign guideline continue to suggest that the use of lactate clearance as a resuscitation goal and elevated lactate level are part of the current criteria for diagnosis of septic shock. Now about biomarkers. Numerous novel biomarkers like SUPAR, pre, Presepin, cell-free plasma DNA are under study with aim of improving diagnostic precision, prognostication, and ultimately predicting treatment response. However, most have shown sensitivity, specificity, and cost efficacy needed to justify their use in a clinical practice. PCT is most studied septic biomarker, precursor to the hormone calcitonin. Levels are routinely elevated in setting of systemic infection. Thus far, studies showed PCT to be useful in decreasing duration of antibiotic treatment, healthcare cost, and the length of hospitalization and adverse event. That said, elevation of the PCT can also be seen in uninfected patient. For example, modest elevation in PCT are common in patients with renal disease requiring adjusted interpretation. Based upon available data, surviving sepsis campaigns suggest using PCT only to limit and discontinue antibiotic therapy. It should be emphasized that elevated or normal PCT level alone are insufficient to justify initiation of antibiotic. Then about molecular technique. Identifying and treating an offending organism in timely manner is often challenged. Conventional blood culture can take up to 72 hours to provide definitive result, while recently developed molecular technique can detect pathogen far more quickly. Ongoing evaluation of pathogen identification technique using multiplex polymerase chain reaction, PCR electrospray ionized mass spectroscopy, and functionalized nanoparticle coupled with the magnetic resonance have demonstrated the capability of identifying organism in under 6 hours with reasonably sensitivity and specificity. Further studies and cost analysis will determine whether these techniques are incorporated into general clinical practice, but in near future, this technique may very well obviate the need for conventional blood culture. Now about adjunctive therapy. Steroids, despite dozens of trials, the role of corticosteroid in sepsis remain controversial. In 2021, Surviving Sepsis Campaign guideline recommended 200 mg per day of IV hydrocortisone, either given 550 mg every 6 hours or as a continuous infusion for patients who have persistent circulatory failure despite adequate fluid resuscitation and vasopressor therapy, defined as a dose of noradrenaline more than 0.25 microgram per kg per minute at least 4 hours after initiation. This recommendation is largely based on two recent major corticosteroid trial and somewhat discordant results. So first is adrenal trial, randomized septic shock patient to receive hydrocortisone versus placebo. While no difference in mortality was noted, there was significant improvement in the reversal of shock and ICU length of stay, ventilator-free days, and need of blood transfusion. On the other hand, another multicenter RCT administering hydrocortisone plus fludrocortisone versus placebo to patient in septic shock did find a reduction in all-cause mortality in treatment group along with the shorter duration of shock, ICU length of stay, and organ support. Much like evidence, critical care community remain divided on the use of steroid in septic shock. Now about vitamin C. The use of vitamin C in patients with sepsis and septic shock is no longer recommended in the latest surviving sepsis guideline. Since the heavily publicized observational study in 2017 that claimed reduction in the mortality, multiple subsequent RCT have failed to show benefit and in some cases have demonstrated harm. About blood purification. Endotoxin is circulating in 50% of patients in septic shock and is associated with poor Euphrates trial attempted to neutralize endotoxin via hemoperfusion with polymyxin fiber device. Euphrates was the large city to study this technology, but was terminated early due to failure to achieve primary mortality endpoint. However, while it did fail to show mortality benefit in overall trial population, the post-hoc analysis found that poly-B hemoperfusion decreased the mortality in subset of patients with moderate endotoxin activity as opposed to extreme endotoxin activity. So, based on these findings, the Tigris trial is currently enrolling patients to evaluate hemoperfusion in patients with moderate endotoxin activity septic shock. Other techniques such as extracorporeal plasma filtration to remove pro and anti-inflammatory mediator from bloodstream are under evaluation. While the concept remains appealing at this time, data are lacking to support routine adoption of any blood purification technologies for sepsis. Now about glycemic control. Glycemic control in sepsis is much debated topic. On the other hand, hyperglycemia can exert immunosuppressive effect, diminishing the body's ability to mount competent immune response. On the other hand, the anti-inflammatory effect of insulin may inhibit cellular autophagy and negatively impact the patient's capacity to clear infection. Evidence showed that severe hyperglycemia in patients with sepsis is associated with increased 30-day mortality. So, on the other hand, NICE Sugar Trial, a large multicenter RCT, compared intensive insulin control to the that is 80 to 108 mg per day to conventional insulin control that is 180, found increased rate of hypoglycemia and mortality with intensive insulin control. As both hyperglycemia and hypoglycemia are associated with adverse outcome, current recommendations are to start insulin after a blood glucose level exceeds 180 with goal of maintaining levels. About anticoagulation, the use of thrombomodulin for the treatment of sepsis-induced disseminated intravascular coagulation has been well established in Japan for several years, and Scarlet trials sought to determine if benefit would extend to large heterogeneous population. Unfortunately, this large international RCT failed to demonstrate any mortality benefit in patients with sepsis-associated coagulopathy. Other anticoagulants such as antithrombin and heparin also have been studied, yet neither are recommended as a therapeutic modality. However, prophylactic anticoagulant use remains recommended in the septic shock guideline. About intravenous immunoglobulin. Acquired immunosuppression leading to low endogenous immunoglobulin level may impact mortality in patients with sepsis. Thought to mitigate the inflammatory response and augment immune mechanism, IV immunoglobulin has potential to modulate both pro and anti-inflammatory process. Thus far, intravenous immunoglobulin has not shown to improve mortality in patients with sepsis. Wide infusion of polyclonal IVIG containing IgG, IgA, and IgM showed more promising result, including modest reduction in mortality. Reliable data regarding timing and dosing of IVIG are still lacking to justify its routine use. As such, IVIG is not currently recommended as therapeutic agent for treatment of sepsis. Thank you, guys.